Hello there and welcome back to another CPD talk. My name's Jasmine, I'm the Blood Transfusion Senior at Medway and the Head of Training for Pathology in NKPS. Today we're going to go through the Massive Blood Loss Protocol, specifically focusing on Medway. What we're going to cover is what massive blood loss is, when and how it should be activated, the role of the laboratory within this, the massive blood loss procedure, essential documentation, and then we're going to have a quick summary. So, what is the Massive Blood Loss Protocol? It's a nationwide strategy that's used to ensure that red cells and other blood components are made available without unnecessary delay for life-threatening bleeding. Each trust will have adapted it slightly to suit their needs, but regardless of where you work, the basis of the massive blood loss will be the same. They will have a massive blood loss policy in place. It's a communication system that will link the clinical area. In particular, it will be places like A&E, theatres, delivery suite and ITU, with clinical staff, anaesthetics, porters, blood bank and the rest of pathology. When is the massive blood loss protocol activated? It can be activated based on different guidelines. So it's normally the loss of total blood volume within a 24-hour period, 50% blood volume loss within 3 hours, a loss of 150 mL per minute, or bleeding which can lead to major increments in pulse rate and falls in blood pressure. To summarise, it's basically any blood loss which is life-threatening. In MMH, the Massive Blood Loss Protocol will be activated by a team leader, a doctor or a paramedic, for example. This team leader should then nominate a team member who will activate the massive blood loss by calling quadruple 2. Which is a fast bleep to switchboard, and they will state, I wish to trigger the massive blood loss protocol in their location, their speciality, and then they will give their extension number. Switchboard will then bleep the transfusion laboratory. This is a voice bleep, so they will explain what is happening, as well as bleeping a porter, and they will also maintain a log of the calls that occur during this time period. This is an example of their record sheet. So they will have the date, the time, the location, name of caller, extension number, whether they've bleeped the right places, and any other places that they've bleeped, and the operator's initials. If the fast/speech bleep is used, this will be an audible call, as I said. So it'll state the location and the extension number for the massive blood loss. And so it's important that we listen carefully. On occasion, you will find that it's a bit staticky, and that's one of the reasons that we test the massive blood loss bleep once a day. If you're finding that that's an issue, you can phone back switchboard and they should have those details available to you. If 566 is bleeped directly, then the extension number will be displayed on the top screen. If it is a 566 bleep, then in the lab we will need to contact the porters as well, and that extension number is on the massive blood loss audit form. We should ensure that we record the number that we're talking with on the audit form, and after we've had a message from the bleep, it needs to be reset properly so that we can continue to receive further messages just in case you end up with more than one massive blood loss that's ongoing. The role of the laboratory in this. When you hear the bleep, the BMS should immediately call the extension provided. They will confirm the massive blood loss call by asking the caller to confirm that they require 6 units of red cells and 4 FFP. You will find that on occasion we will get bleeped for a massive blood loss and all they really want is urgent blood. That's a completely different thing and it is not a massive blood loss. We can provide urgent blood, but it's something that's different from the massive blood loss protocol. If it's not confirmed, then we'll complete an urgent request and ask them to call 5818 in the future. But if it has been confirmed, then we'll complete an audit form to proceed. It's really important when you're filling out the audit form that you obtain all of the details requested on the audit form, and that includes what sort of bleep was used. So if they haven't done the quadruple 2, then we need to remind them to do that in the future, and to ensure that we bleep a porter on the extension shown here. It's important that we confirm the patient's age and activate the appropriate protocol because it could be a pediatric patient as opposed to an adult patient. And then we ensure that the form is photocopied twice so that reception have one and haematology have one, to enable them to prioritise samples effectively. Finally, we need to make sure that we inform the haematology consultant so they're aware of what's going on. This is our current massive blood loss protocol form. You can tell I screenshotted it, which is why there are the red underlines and stuff. Ignore that for now. So what we would do on this is you record the time and date of the call, the name of the caller, the senior doctor invoking the protocol, and their contact number. We then record which type of bleep they've used. This is important because the transfusion practitioner will audit this and will call up the wards if they're not doing it correctly to ensure that their staff are trained in the right way. We then put whether or not it's been confirmed. So this is this point where if they say they only want urgent blood, we would tick no. And we move on to the age. We've also got in there to remind the clinician about emergency ONEG units. Technically, the clinicians in A&E, etc., they should be aware that there is the possibility of emergency O negative if we do not have any current samples. However, it's important that we remind them because in the spur of the moment, it might just be something that slips their mind. We then have to make sure we get all the patient details. I would recommend typing it into our system at the same time so that you can be looking at whether or not we have any samples. And then we also need to request samples for not only group and save if we need further samples, but also for a full blood count and for clotting screen so that we have an accurate picture of the patient's hemoglobin and platelets and what clotting factors they're running out of. You then put down who you are and the sample number of the sample that you currently have. If you don't have a sample, then you can book it in under a BA number instead of a TA number. And then we've got sort of like a little audit of which components are available, whether or not the patient is suitable for electronic issue, and what other things have been issued, as well as a space to put notes. So sometimes you might have a massive blood loss and the porter hasn't shown up for 20 minutes, in which case you can record that in this notes section. It can be really useful to have that just so that at a later date, if you're questioned about it, if it's in 3 months' time, you're probably not going to remember how it all went, how it all happened. However, if there are notes there, it will either jog your memory or it will act as evidence as to what has happened. On the next page, it has the reminder to inform the haematologist, and then we move on to stage 2. Stage 2 is quite different because the components that they can request vary, and therefore there is space for you to just write down what components they want. So, this is an overview of the adult massive blood loss protocol. You can see we've got the bits in blue, which is more of the clinical side, and then moving on to the other bits are more for the lab. So you've got the team leader will assess the need for blood products and whether mass blood loss should be activated, considering consultant involvement. They should have someone taking blood for the full blood count, LFTs, usernees, the blood group, coagulation screen, cross-match, etc., and to mark it as urgent, and also to ensure that they are properly dealing with the patient, so giving tranexamic acid, resuscitating correctly, and continuously monitoring cardiac. The nominated team member will then activate the massive blood loss by dialing the quadruple 2 and saying the phrase that we've already gone through. If required, ask for the acute response team as well. The switchboard will then fast bleep blood transfusion and all the other places, and the porters will be sent to the scene. Blood transfusion will then call the nominated team member back. So this nominated team member is going to be the point of contact between the ward and the lab. So it's really important that we get their name and that they're the one that we're able to talk to repeatedly, because it's been shown that having that point of contact really improves the communication. They will be responsible for clearly identifying the patient details, the urgency of the blood, the name consultant, basically giving us all of the information that we need. The porter or the clinical trained staff will then come to collect stage 1 blood components, as well as sometimes to drop off blood samples, depending on whether they've already been sent. So we will ensure that there are 6 units of red cells and 4 of FFP, and if blood is required immediately and we don't have any samples, then we can use O negative. It's important to note that that will depend on the patient demographic. So we will use O negative blood for patients of childbearing age who are female and for children. For adult males or females who are older than childbearing age, then we would issue emergency O positive blood if possible, just to try and conserve our stocks of O negative. If they need it within 10 minutes and they've sent us down a sample that's awaiting testing, then we can do a tube group and we will issue group specific blood. And finally, if it's a routine one and we've just got the sample, then they will wait until we've got fully cross-matched blood available. And the lab will inform the on-call consultant. If the bleeding continues, then the named contact will call us and let us know to move to stage 2. The porter again will be sent up to get all of the components required. It is important, if you're on the clinical side, not to tell them to come up and just get everything, because there are too many units that we will be issuing for them to get everything. You need to be specific about what blood components that you need, or else we're going to end up wasting blood and other components for no reason. So stage 2 is another 6 units of red cells and 4 FFP, and then the other components will be based on the patient's results from those samples. And we should be having regular samples to assess what's going on with the patient. So if the PT and APTT are not normal, then there may be the need for FFP. The platelet count is low, then again we'll give platelets, and cryoprecipitate is there for fibrinogen. Obviously there are other drugs and pharmaceuticals that can be used specifically in the clinical area. Moving on to the pediatric massive blood loss protocol, this is very similar. The only difference is the amount of units that will be issued. So in this case we'll be looking at the patient's weight. So you have to think that if we were to give a baby who is only a child who is only 20 kilograms, 6 units of red blood cells, then you're probably going to overload that baby and make them sicker. For that reason, we will have 2 different protocols. We will have the one for patients that are greater than 40 kilograms and one for patients that are less than 40 kilograms. The greater than 40 kilograms is basically the adult version of the massive blood loss. The less than 40 kilograms halves that, so it will be 3 units of red blood cells and 2 units of FFP, and that will be the same in stage 2 as well. So it's very important in these cases that we don't overload the patient. Everything else though will be the same. The only thing to bear in mind at Medway is that we obviously have the protocol in place where pediatric patients are expected to get irradiated and CMV negative blood, so that may need to be waived depending on that patient's requirements. This is sort of summarising the provision of blood section that I've kind of gone through. As I said before, in terms of use of O negative, you would give it if it's a female, childbearing age, a child, or a patient that's unknown gender, because obviously if we haven't been told what gender the patient is, we don't want to give them O positive and it turn out that they could have children later on. If it's a male or a female of greater than 15 years old, then O positive should be issued, and if it's a neonate, then a neonatal emergency blood is available for them. The things to note is that if we only have one sample or the group is not confirmed, we will always issue group O and following the above procedure. If we have the 2 samples taken at 2 different times, that's when we can issue group specific. It's important in the lab that you start thawing the FFP as soon as possible after the call, as it takes approximately 20 minutes to thaw. If it's an unknown group or not confirmed, then AB or A plasma should be selected. In any case where you're dealing with a patient where you have no history, you would book the patient onto Apex, authorise the G as a not known, and then blood track can be used. Once issued to the patient, update the unit on blood track to available and reprint the compatibility label. If group confirmed, select group specific plasma. Overall, the biggest things to remember about the massive blood loss is communication is critical at all stages to avoid delays and misunderstandings. For the clinical team, it's important to assess the urgency and inform them of the products available. So you might get someone phoning up and saying they need urgent blood, But if you explain the possibility of giving them group specific, they might be able to wait that long. We're not down there, we don't know what's going on. It's really important that we explain the different options that are available to them. When discussing with other laboratory staff, it's important to let them know. So if you are on the cross-matching bench and there's someone on the authorising bench and they have a sample on this patient, if they don't know that that is a patient who is bleeding, then they may not prioritise it in the correct way. So it's important that we tell them what's going on. Same with the people booking in the samples. If they know that there's an urgent sample coming, then they'll bring it straight to you. The next thing is to keep an eye on your stock levels. If you've got a patient that is group O neg and they require certain requirements, then we may need to order more stocks in. And make sure that if it is too overwhelming, that you ask for help. There are normally other BMSs around. If you're on your own, then we normally have someone on standby. They're there to be phoned in. Make sure that all of your documentation and sample processing has been completed at the end. So I understand at the beginning when you're rushing, there might be some bits of the form that you haven't completely filled out, you've made small notes on. Before you hand over or leave, make sure they are completed, because otherwise we're going to be chasing you up to finish it off. And finally, once you've got more samples and you can confirm whether or not the patient's blood is compatible or not compatible, ensure that you add the correct coded comments onto this so that it is obvious on Apex that we know what's going on. So that's pretty much it on massive blood loss. These are the essential documents relating to it, so please feel free to have a look through them if you haven't already. But that's it. It's not actually as complicated as it seems. To be honest, it's just that panic in the moment because you're trying to get everything out really, really quickly. If you have any other questions or want to go through this in more detail, then please feel free to come and find me. Otherwise, thank you all so much for listening. I hope it's been of use to you. Please try and complete a reflective log on the CPD, and I look forward to the next talk. Thank you very much. Bye!